So I've decided to do a video on why catheter ablations, and for that matter, a lot of surgical ablations for atrial fibrillation, don't work. So let's talk about what determines the success of a catheter ablation procedure. Because I think there's several myths going on about catheter ablation procedures. When people have an ablation for their atrial fibrillation, I hear stories of, a patient will tell me, I have friends, and one friend, they did the ablation, they got rid of my friend's AFib in one shot. And then another friend needed 3 procedures. The implication there is that, well, friend A's doctor must be great because they only needed 1 procedure, and friend B's doctor isn't very good because they needed 3 procedures. Well, that may or may not be true. It really depends on what amount of AFib or what stage of AFib were their friends having, and that will determine whether or not the doctor is good or not. Because when you're talking about success rates of atrial fibrillation, the number one factor, absolutely the number one factor, is how much AFib do you have? What is your stage of atrial fibrillation? Remember, AFib is a progressive rhythm problem. Once you develop these abnormal AFib cells and they start to wake up and cause rapid heart rates and episodes of AFib, the longer you have AFib, the older you get, the more AFib cells form, and like a little forest fire, it's growing. So there are actually stages to atrial fibrillation, almost like there are stages to a forest fire. There's early stage, which we call paroxysmal atrial fibrillation. There's middle stage, which is persistent atrial fibrillation. Late stage, which is long-standing persistent atrial fibrillation. And then end stage, which is permanent atrial fibrillation. And so remember, if you're having episodes of atrial fibrillation lasting for hours or days, basically you're in it maybe 10, 20, 30% of the time, that's an early stage of AFib. You don't have AFib on that many walls of your heart. That's why you're not in AFib that much. But as you get older, you keep forming more and more and more AFib cells. And the more walls you have it on, the more AFib cells you have total, the more it wants to wake up and the less it goes to sleep. So that's where you progress into a middle stage. That's where you may have it on, instead of 1 or 2 walls out of your left atrium, you might have it on 3 or 4 walls. Maybe now your atrial fibrillation is waking up 40, 50, 60% of the time. And then if you go to the late stage and you have atrial fibrillation cells on 4 to 5 out of the 6 walls, that's when you're in AFib maybe 80, 90% of the time. And when you finally get it on all 6 walls, covering your entire forest, that's when you're in atrial fibrillation 100% of the time. And then stay that way for 5 years or more. Now you have so many AFib cells, we can't get you out of it. That's when ablation won't work, no matter who's doing it. The strongest drug to keep it asleep won't work. You will just stay in AFib for the rest of your life. But because AFib is not directly life-threatening, you will never directly die from AFib, as long as you don't have a clot and a stroke, which is the most important thing. But symptom-wise, we don't have as many ways to treat it. We can just slow it down with rate-controlling medications and have you tolerate it, and you will live just as long as everybody else, but we can no longer put it to sleep or get rid of it. So when you are dealing with an atrial fibrillation ablation and you say, what's the number one factor that determines the success rate? It's not the energy source, which people think. It's usually how big is your AFib forest fire? What stage of AFib are you in? Are you early, middle, late, or permanent state, like a forest fire? If you're putting out a forest fire as a firefighter, you need to know how big the fire is. A 90% forest fire is a whole lot harder to put out than a 5 or 10% forest fire. And you're gonna need a firefighter with a lot more skill to try to put out a 50 or 90% forest fire. At 5 or 10%, it may not matter who's putting a forest fire out, because who can't put out a 5 or 10% forest fire? So that's why the analogy of, I have a friend who only had 1 ablation and another friend who had 3 ablations. Well, is friend A's doctor better than friend B? Only if both friends had the same size forest fire. If they're in the same stage of atrial fibrillation and one doctor only needed 1 procedure and the other doctor needed 3, well then of course, Dr. A is probably better than Dr. B. But a lot of times, friend A had a very small early stage paroxysmal AFib forest fire, 5 or 10%. Anyone could have put that out. And then maybe friend B's had it for 10, 15 years. They're in it 80, 90% of the time. They have late stage AFib, and maybe only those of us who specialize in very complex ablations could put that out. So maybe friend B's doctor might actually be better than friend A's doctor, because you have to compare apples with apples, not apples with oranges. So number one, how big is your forest fire? How many walls are involved in the heart that are causing the AFib, how many walls worth of AFib. That's number one. That's always number one. Number two, then it becomes the skill of the person doing your procedure. Obviously, if you have a forest fire and you choose a firefighter to put it out, or you have a very progressed forest fire, are you going to choose somebody just fresh out of training or with 1 or 2 years of experience, or a 30-year-old veteran who specializes in this and has a track record of putting out big forest fires? Well, obviously, experience matters. And so therefore, unfortunately, when we come out of training as cardiac electrophysiologists, remember 4 years of medical school, 3 years of internal medicine residency training to be like your primary care doctor's level, 3 years of cardiology fellowship to become a regular cardiologist, and then 2 more years to specialize in the electrical part or become an electrophysiologist. When we come out of training, people know how to do that first wall, the one wall forest fire, the early stage AFib. And if you do that one wall for an early stage, 70-80% of the time, you're gonna get rid of all the AFib. But a lot of doctors never progress their skills, or that's what they do for their entire career. So if you have an early stage AFib, then I don't really care who you go to. Whoever goes to is gonna probably have a high 70-80% or higher success rate in getting rid of your forest fire. But if you have a later stage forest fire, this is why easy is easy and hard is hard. If you have an easy stage forest fire, it doesn't really matter. If you have a late stage forest fire, a difficult forest fire, it can make a big difference who does your ablation. So number one factor, how big is your forest fire? What stage of AFib are you in? And then number two, the skill of the operator. Then a distant third is the actual energy source, whether we freeze it, cauterize it, or use the newest technology, whether we use pulses of electricity or electromagnetic fields to denature the cells. Honestly, the energy source is not as important as who's doing it and what their lesion set is, because it would be like the analogy of the forest fire again. If you have a forest that's got divided into 6 quadrants, and we say, 5 of the quadrants are on fire, and we assign people to put those fires out, well, whether or not somebody's actually targeting all 5 quadrants of the forest fire or just one quadrant is gonna make a big difference as to whether they get it all. And then of course, their skill in actually getting rid of what they're doing. So it's, are they doing a lesion set on enough walls based on your stage of AFib to actually hit all the areas that your forest is on fire? And then number two, how well are they actually putting out the fire? Are they making deep enough lesions into the walls of the heart to actually get rid of all these cells? Or are their lesions very superficial? So I have a heart model here today, and we're going to point out exactly what I'm talking about. So the chamber of the heart that AFib forms in is actually the left upper chamber of the heart. We call that the left atrium. So remember, the heart has 4 chambers. There's 2 bottom chambers and there's 2 upper chambers. This is the right atrium. This is the left atrium, right ventricle, left ventricle. So we are talking about AFib is forming in the walls of this left ventricle. The right atrium, the right upper chamber of the heart, and the roof of that chamber, that's where your normal source cells that are supposed to be in control of your heart reside. And then the bottom chambers, these muscular chambers, that's what actually pumps the blood out of your body. The top chambers do not pump the blood directly out of your body. They're like primer pumps. They just kind of help push the blood down to the bottom chambers so the bottom chambers can pump them out. That's why they're not super important, but they are still important. So the left upper chamber here is where AFib resides. So if you open this up, you can see that this chamber is kind of like a room. You could think of this chamber as being almost like a room. There are 6 walls, just like this room has 6 walls. This room has a back wall, a front wall, a roof, a floor, and 2 side walls. Similarly, this chamber has 6 walls. There's a back wall, we call that the posterior wall. There's a front wall, it's called the anterior wall. There's 2 side walls, we actually designate that as this side wall, and the outer side wall is called the lateral wall. This middle side wall is called the septal wall or septum. And then there's a roof and a floor. So 6 walls, just like a room. Now, you'll notice that, and this is the back wall of that chamber, you'll notice that in the back wall, there's actually 4 veins, these red vessels that are entering that back wall. We call those the pulmonary veins. They're actually blood vessels that are draining blood from the lungs. The blood is picked up oxygen, so it becomes this bright red arterial blood. You stab your artery and the bright blood spurts out, versus like a vein where you have dark blood, you're giving blood or giving a blood draw or giving lab work done, the dark blood just dribbles out. Oxygenated blood versus non-oxygenated blood. But these veins are actually draining blood back to this chamber so it can go down to the bottom chamber and be pumped out to the rest of your body. So we call these the pulmonary veins, or veins coming from the lungs. Now, they actually enter this back wall in the four corners. So we know that AFib forms always on wall number 1, which is the back wall, specifically in these four corners. That's actually where the AFib always starts. So when I say somebody does a simple one-wall ablation, what they call pulmonary vein isolation, or PVI for short, which is what everybody out of training, every EP out of training knows how to do, but not necessarily more than that. That's what we're talking about. We're talking about getting rid of the AFib cells around these four corners. It's actually like half a wall's worth. It's not really the full wall, but it's sort of the one main area. So usually what we do is we make a little circle of ablation around here, because in the old days, 20 plus years ago, when we first started doing this, we actually tried to destroy the AFib cells that were right in the corners of where that vein enters, and we would actually go burn in the vein a little bit and actually damage the vein. So now we just make a little circle of ablation or scar around these to kind of trap those signals in. That's what's pulmonary vein isolation. That's the most basic ablation that can be done, and that's what a lot of doctors do, even if you need more. So think about it. If you're at an early stage forest fire, that's all you have, and you're an AFib, 5, 10, 15, 20% of the time, then I don't really care what energy source you use. Whether you freeze it, you cauterize it, you use pulses of electricity, you're gonna be shooting for a 70 to 80% success rate. That's pretty standard. The problem is your AFib is always growing. So if it spreads to, say, the sidewall here, well, just doing those four corners isn't gonna get it. If it spreads to the back wall here, it's not gonna get it. If it spreads to the front wall, it's not gonna get it. Or the floor, or even to this right upper chamber. I know that there are actually 6 major areas that the AFib spreads to over time as you get older. So it always starts here in the corners. That's sort of the first area. It's kind of like a one-wall ablation. And then it spreads to this sidewall, this little pouch-like structure called the left atrial appendage that's on the sidewall. That's the second area that AFib cells or sources start to fire off in. That's kind of the sidewall. Then it spreads directly to the actual back wall, middle part of the back wall. That's kind of the third area. Then it goes to the floor. This little vein structure here that's on the outside of your heart, called the coronary sinus. It's actually draining blood from the outside of your heart. It's actually touching the floor of that chamber, and that is the fourth area that it forms in. Then the fifth area that it forms in is actually this front wall part, and then here on the right side chamber, the right atrium, that's actually the sixth area. People in the latest stages or close to permanent stage, that's when they have it on all 6 walls, and they're in it almost virtually 100% of the time. They can become permanent. So depending on how big your forest fire is, you need to match the lesion set to get rid of it appropriately. You can't say, well, I've got 4 different areas. I got the back, corners to the back wall. I got the back wall itself. I got this side wall, and I got the front. But somebody just did these corners and they expected to get it. Well, that's why the success rates drop from 70 to 80% in these later stages to 40 to 50%. And then when you have it on virtually all 6 of the areas, that's when if you just do this simple 4-corner ablation, your success rates are gonna drop to 20 to 40%. I don't know about you, but 20 to 40% or even 40 to 50%, it's pretty low. That's like less than flipping a coin, honestly. So that's why the very few of us who specialize in more advanced ablations, my success rates at the middle stage is actually still 85 to 90%. And then for the end stage, all 6 walls, I'm still shooting for 75 to 80% because you need to match the lesion set with what stage of AFib you have. And that's where people get it wrong. I've had people tell me, well, look, I've had 2 previous ablations, and the first time they tried to cauterize it, and then the second time they tried to freeze it, and I still have a bunch of AFib. And now the newest energy source, pulse field ablation, just came out. I'm scheduled for that next month. I'm sure that this is gonna get it. Why would that get it? The energy source is less important than what's being done. Likely, this person had multiple sources of AFib on multiple walls, and yet somebody's probably just doing the 4 corners multiple times. First, they did it by cauterizing it. Then they used the freezing energy source, and now they're gonna use pulses of electricity. I don't really care what energy source you use. After 2 or 3 times, I'm sure they got rid of those areas and it's just scar. But if you're not hitting where else the forest fire is, you're not going to get the results. So it's not the energy source, it's what you're doing. And then the second thing is, how well are you doing what you're doing? Are you making a deep enough lesion to actually get rid of all the AFib cells in that wall, or are you doing a very superficial lesion? Now, cauterization, freezing, the pulse field ablation technology, they make similar lesion depths. They've been proven in that first wall to all have similar success rates. The advantage of the cauterization or radio frequency is that catheter can reach anywhere if you have the skill. It can reach all 6 walls of the left atrium. It can reach walls of the left atrium and the right atrium. And you can go up on the power or down on the power to make deeper burns. It takes a lot more skill, tremendously more skill, and then to alter the power settings, you have to be very careful, because if you go at a very high power setting to make very deep burns and get a better overall result, you could make holes in the walls of the heart. That's why you have to be very careful and have a lot of skill. The freezing balloon can only technically reach this back wall where these pulmonary veins are. So if you put this back on, the freezing balloon can only reach here. They just sort of fit in the 4 corners like a rounded balloon, and you just let go and they freeze a nice circle around those 4 areas, and that's physically all it can reach. Maybe a little bit of the back wall, but pretty much that's it. So it's really not meant for more advanced ablations. The newest energy source, pulse field ablation, it can reach a lot more areas. It potentially has the ability to reach other areas the way the cauterization catheter does. The problem is it's just such a new technology that came out in late 2023 that it's only been proven on the 4 corners of the back wall, the very simple first wall ablation. That it gets similar success rates, 70–80%, not any better than cauterization or freezing, but it hasn't yet been proven in any of the other walls. So in the future, if we find that it makes deep lesions in the other walls similar to cauterization, then those of us who do advanced ablations may use it for that. But for right now, you can't really use it for that because you don't know what it's going to do or whether it's going to be good enough. It's just completely not been studied yet. And so when people jump to pulse field ablation and brag, I'm doing 6 of them a day, it's because they're just doing the simple 1 wall, 4 corners, 6 people per day, no matter what your stage of AFib is. And that's why they can do 6 a day and then do multiple redos and just make a lot more money, unfortunately. So this is where you have to match the lesion set and you have to make a deep enough burn. So those are the 2 most important criteria. Now, let's briefly touch about surgical ablation. Surgical ablation is considered to be a more gold standard, where you're going to get a higher success rate because you have surgeons actually opening up your chest or making holes to your heart and actually making burns on the outside of your heart. Why is this sometimes more effective than us making burns on the inside of the heart? Because you have to have deep enough burns that actually destroy the cells deeply in the walls. And a lot of these cells are actually more towards the outer wall surface versus the inner wall. And so it's very hard to make a deep enough burn from the inside, what we do, to really get rid of all the cells. That's why we're talking about lesion depth. Are you making a deep enough lesion? Cauterization, you can do that if you up the power and know what you're doing and don't make holes in the walls of the heart. The other cryo balloon and pulse field, they make a little bit more superficial lesions, and that's why the success rates aren't as good. So there is a Dr. Wolf who does what he calls the Wolf procedure or Wolf mini maze, and he has a video on why catheter ablations don't work compared with surgical ablations. And his point, which is a good point, is that you need to make deep enough lesions, and a lot of these cells are more on the surface part of the heart. And so a surgeon can reach that, whereas those of us who do this from the inside have a lot more difficulty. Of course, the flip side is if you have surgery, you have to have holes to the outside of your heart. It's a lot more invasive. It takes a lot more time to recuperate from than us doing this from the inside, where you can leave the same day or by the next morning and just have little punctures in your leg veins. So obviously our way is safer, but harder, because how do you make these deep lesions? So the way I do it is I do high power radio frequency, which is cauterization, for short duration, short bursts, to sort of get a deep lesion without making holes in the walls of the heart. But that's a very advanced technique. Not everybody does that. Other people just do pulse field ablation, cryo balloon, radio frequency at low power settings, and they make more superficial lesions. That's why their success rates aren't as good. So Dr. Wolf's point of doing it from the outside does have advantages, but it is a much more surgically involved procedure. Now, he does a procedure called the Wolf mini maze or Wolf procedure. And that's where he essentially, so those are 2 out of the 6 areas. It's very good. And by cutting this off, that's where 90% of the clots form when you have clots and strokes with AFib. So he's saying it's safer if you don't go on a blood thinner, because now you're less likely to have a clot and a stroke. So he's saying, touting that as an advantage. But he doesn't actually go after all the other 4 areas that we talked about that AFib comes from. It's not just the four corners. He doesn't do anything on the back wall. He just does the four corners. Yes, he does do this appendage structure, the sidewall, but he doesn't do anything on the floor from this coronary sinus vein. He doesn't do anything on the front anterior wall, and he doesn't do anything from the right atrium. He just does those two areas. What he does do is he ablates what's called ganglionic plexi, or GPs. These are nerves on the outside of your heart that actually control your autonomic nervous system. Your brain's controlling your heart. It's telling it to speed up if you're stressed or in pain, or it's telling it to slow down if you're sleeping or just ate a large meal. It's very well known that these stress responses, these autonomic nerve fibers that your brain sends to the heart, can help trigger AFib. So he doesn't directly get rid of all the AFib sources. He basically just does 2 out of the 6 sources, and then he ablates some of these nerves so that the remaining AFib sources are not triggered as easily. And he's saying that's getting, really good results. You can see that it's not getting rid of the AFib sources directly. The flip side also is that by disrupting your autonomic nervous system inputs to your heart, it means your heart doesn't vary with activity or with stress or with emotions as well as it normally would do, because you've kind of blunted some of those signals from your brain. So he's saying that's better than being an AFib, which is probably true, but there are other ways to get rid of the AFib sources without destroying the autonomic nerve fibers to your heart and how your heart varies. There is a very involved procedure called the Cox-Maze 4 surgical procedure. This is the true gold standard. It's open heart surgery, very, very involved, but it actually does a very complex lesion set. It gets rid of the 4 corners, which everybody does, from the outside. It gets rid of the cells right on the back wall directly. They actually make a line from here to here and here from here, and they kind of box it out so that there's no more signals in there. So that's sort of the second area. They cut off this appendage area. That's the third area. They make a line of ablation on the floor, which is the fourth area. And then they actually go to the right atrium and they make a lesion through this side wall and also on the floor to hit the sixth area. So it's an extraordinarily complex lesion set from the outside of the heart that has extraordinarily good results. Dr. Wolf's procedure doesn't do that. He's saying it's simpler and you get similar kind of results, but that's open to interpretation as to whether that's really true or not. Definitely the people who do the more involved, all 6 walls, which is major, major surgery, might disagree that, for years they've been doing this super complex thing and hey, I only have to do 2 walls like Dr. Wolf and get the same result. Well, I don't know if that's really true or not, but they obviously don't believe that. But that is sort of the gold standard, but that's major, major surgery. So you can see why even when people have a surgical procedure and said, I had a surgical AFib ablation, 99% of the time, what they had was not the full Cox-Maze 4 procedure, that's major, major open heart surgery, not the procedure that Dr. Wolf does, because he's one of the only people who does it in Houston, Texas. When people say they've had a surgical AFib ablation, what they're talking about is a regular cardiothoracic surgeon in any city of the world is basically doing open heart procedure to do a valve replacement or a bypass surgery. And they said, while we have the heart open, we can just make some burns around these 4 corners and do kind of what the EPs mostly do and just do it from the outside. And that's what they do. But that's not the same thing as the Cox-Maze 4. It's not the same thing as even what Dr. Wolf does, because he does the 4 corners and cuts off this appendage and does the ganglionic plexi. If you just do the 4 corners, even surgically, your success rates are going to be kind of like what everybody from the inside does, just doing the 4 corners. It's really going to be about the same. So I agree that surgical ablations can be more effective, but the average surgical ablation is still just as simplistic as what most EPs do from the inside. And that's why most catheter ablations from the inside, because they're not matching the correct lesion set with the number of walls needed for your advanced stage of AFib, if you have a more advanced stage of AFib, and they're not making deep enough lesions to reach all the cells, that's the main reason why catheter ablations from the inside fail. And the reason why most surgical ablations from the outside fail is because most surgeons are just doing simple 4 corners just from the outside, and that's not enough. Yes, it's deep, but it's not enough. It's not a complex enough lesion set. So that's why I believe most catheter ablations and most surgical ablations don't work. Now, to finish up, the way I do it, and the few of us who do specialize is, we do more than just the 4 corners. I can actually do the 4 corners at a higher power setting. I can actually box out this back wall and hit that and isolate the veins there, all from the inside, not necessarily from the outside. And then we can also go into this vessel here and burn the floor through the vessel. That's the third area. And then I don't clip off this appendage, but I do make a half circle around it to block signals coming from that. That's the fourth area. And then the fifth area, we can make a line on the floor of this area and a half circle around, a complete circle around this appendage structure. That's the sixth area. So this is showing that you can actually get most of the results of the Cox-4 surgical advanced ablation, but all done from the inside. You have to match the correct lesion set with your stage of AFib, and you have to make a deep enough burn, a full wall thickness burn, to actually get the result. But it is possible for the inside. It's just very difficult to do and takes a lot of skill, but it is definitely possible. For everything atrial fibrillation related, please feel free to go to my website, drscottlee.com, where you're going to find more resources and also can follow me on social media.